Hello everyone, so we're going to continue with our discussion. As I promised, is that continuing clinical scenarios, I'm going to summarize all the case scenarios of the pulmonary system in small words. Like these words, when you see them in the clinical vignette, this could raise an alarm and this means something. Okay? That's something I wished somebody did that, but I couldn't find any resource for that, so I plan to do it for every single question. So okay, we'll continue. Okay, so 60, let's say a clinical scenario, she's 60-year-old, cough and a fever. You're gonna see that a lot, fever and a cough. Okay, so you do exam, there is a decreased at the right lung base with dullness to percussion. So decrease of breath sounds, dullness to percussion, but here is the question. Okay, so dullness, decrease of breath sounds, what does that mean? Maybe pneumonia, others. So you do chest x-ray. Chest x-ray shows consolidation. Okay, and then thoracentesis, you do thoracentesis, shows pH of 7.1, glucose 45. So this is kind of concerning, all right? This is actually diagnostic. So what do you wanna do for this situation? Okay, so the best next step would be chest tube. Okay, and that brings us to the discussion, what's the difference between complicated and uncomplicated parapneumonic effusion? So the one uncomplicated, usually sterile exudate in the pleural space and small to moderate and free flowing usually in the radiology, but in the complicated you will tend to see bacterial invasion of the pleural space, and then you see moderate to large free flowing or loculated, like in this patient, loculated. And then the main difference is the pH. If it's less than 7.2, that's the number. pH less than 7.2, glucose less than 60, white BC more than 50,000. Just like in the septic arthritis, more than 50,000. It's a big number. LDH more than 1,000. So any of these things, this is complicated. The uncomplicated is lower, like pH is more than 7.2, glucose more than 60, and leukocyte less than 50,000, and the LDH less than 1,000. And then the gram stain in the complicated could be positive or negative, but in the uncomplicated it's negative. You give antibiotics for both, but complicated you need drainage, you need chest tube. Okay. Empyema, usually when it's advanced progression of complicated, usually called empyema. And then that brings us another discussion. When do we do thoracentesis? Okay, we do thoracentesis if there is a free flowing or large pleural effusion, if there is more than 10 millimeter on the lateral decubitus film, if there is loculation also, you need to drain it. If there is thickened pleura, parietal pleura, on contrast CT scan, you want to drain it as well. And if it's a clearly delineated effusion by ultrasound, if it's like a clear, like you can get a good shot on it, that's a good idea to drain it. All right. So now there is another case. This was a good thing about the pleural effusion. Another case scenario, you see 73-year-old man came in with dyspnea, right? And JVD 7 centimeter H2O, okay, a little bit standard. There's wheeze, okay, there's edema in lower extremity, heart rate is 114, there's some hypoxia, 89 on Romer. So lower extremity edema, there is like some wheezing and some JVD, and hyperinflated lung on the chest x-ray. There's some atelectasis. So atelectasis, so chest x-ray didn't show much, there's atelectasis. But there's tachypnea. So if you calculate Wells score criteria here, what do you see? You see tachypnea, there's immobilization, you can give you immobilization, that'll give you 1.5. Previous PE or DVT, if there's a clinical signs of DVT. So this patient has clinical signs of DVT, that's 3, and then has heart rate. So this increases for criteria for pulmonary embolism. Other thing, hemoptysis or cancer, each 1 point for each. And so also the other diagnosis is less likely. Here we couldn't find other diagnosis. X-ray is okay. Why is the patient hypoxic? So we don't know, right? Okay. So what would you do? The best next step? You do CT, PE, CT angiography. Okay, CTA, PE protocol. Alright, so you get another patient. You see 62-year-old man came in with fever, chills, shortness of breath. Exam shows crackles. Respiratory rate 22. Okay. So he has the respiratory distress, and he ended up being intubated, right? And you put them on the tidal volume. Okay. So you end up intubation, and then they give you the intubation setting. Okay, crackles, fever. Then intubation, they give you the respiratory rate 22, tidal volume, let's say it's 500, and then they give you ABG as well. pH is 7.3, PCO2 38, PO2 63, right? So we have a bunch of numbers, you know. Tidal volume is 500, FiO2 is 60%, PEEP is like around 5, pulse ox is 94 on assist control, and then they tell you, okay, what would you do in the vent setting of this patient? This is a common question that you get asked about, right? So what would you do? Okay, this is something that is called auto PEEP, which is caused by air remaining in the lung due to incomplete expiration in mechanical ventilation. So how do you correct the auto PEEP? To correct the auto PEEP, like this air inside the lung, there are a few things: either reducing the minute ventilation, or increasing the expiratory time, or giving medication to treat airway obstruction. So in this case, how can you decrease the minute ventilation? The way you decrease it, you can by decreasing respiratory rate. You can either decrease because minute ventilation, respiratory rate by tidal volume. Okay, so this patient you want to decrease respiratory because this is a little bit high, 22. Tidal volume seems to be okay now. So this is what you want to do. Vent setting is very important. Even if you want to work in rural hospitals or so, you need to know vent setting. So either decreasing respiratory rate or tidal volume in this case. Alright, so now we have 72-year-old smoker, came in with fever, shortness of breath, man or female, doesn't matter, you know, crackles on exam. And they give you a bunch of labs. So you do chest x-ray, there's infiltrate, and then the patients end up needing to be intubated, right? And the question is, what is the next step that you would be the best thing like you want to do? Okay, this patient was very sick, there are some crackles, may need to be intubated as well. So what is the best next step? In this case, this patient is critically ill, right? They want to know, when do you start enteral nutrition? Okay, so there are a bunch of the improvement, a bunch of questions. Start after a day, don't start nutrition now. What is the options? Okay, the correct answer is enteral nutrition within 48 hours. This is very important. So now that brings us to the discussion of nutrition in a critically ill patient. So how do you treat? Enteral nutrition is preferred. Initiate within 24 to 48 hours and advance to goal over 48 to 72 hours. Withhold nutrition if somebody is hypotensive or escalating vasopressors. You hold nutrition. Gastric feeding tube is preferred. You can do jejunal feeding if intolerant to gastric feeding or high risk for aspiration. Somebody couldn't tolerate the gastric tube, you just do jejunal. And then you do prokinetic agent if they're feeding intolerant, prokinetic, so that you move their bowel movement, okay? So now we have another patient. We have a couple. This is a ventilation patient. It's important. So now we have this patient. He's 89, have GI bleed. So he ended up being intubated. Hematemesis, end up being intubated. Okay. Tidal volume 200, respiratory rate 28. But there is good air entry on the exam. There is bibasilar crackles. Okay. And there is bilateral airspace disease in this patient. And they give you the respiratory rate is 28 and tidal volume is 200. Okay. And then they will ask you the bunch of questions. Best next step. What do you do? Do you do extubation? Do you place the patient on assist control? And or do you keep the ventilation? Okay, pH is okay. PaO2 99, PCO2 29. So everything looks good, right? So what would you do? Do you extubate or not? That's what they're asking. Okay. So what would you do for in this case? What you want to do is that you want to assess if they're able to be extubation. You need a few things. You need to make sure they have strong cough, absent airway lesions, there's a few secretions, there's good mental status, they're able to follow commands, you know. There is another thing that's very important is RSBI, okay? And this is the question is about understanding, if you make sure you understand that or not. RSBI is respiratory rate divided by tidal volume in liters. So in this case, it's going to be 28 divided by 0.2 because 200 is the tidal volume, right? I'm out. So 0.2. This gives us RSBI of 140. What's our goal? Our goal is below 105. Below 105. So this patient is not ready yet. So what you want to do? Put on assist control, okay? That's what you want to do. And continue daily SPT, consider tracheostomy after 10 to 14 days if you can't get them off the vent, okay? But if the patient have RSBI is below 105, good mental status, follow command, fewer secretions, strong cough, we start asking the cough, absent airway lesion, upper airway lesion, then you can extubate the patient, okay? So this is the question you want to test you. When do you extubate the patient? When you do not, right? Because you could work in critical care setting and you need to know this information. Alright, so now we get another case. Alright, so another question, like somebody like stuck by a wasp, like 23-year-old, came in with wheezing, okay? There's good air entry and all of that, but there's increased bowel sounds. So what's best next step, you know? This patient, blood pressure is kind of low, a little bit tachycardic, so you suspect shock. So you do IM epinephrine. This could save his life, right? 23-year-old. Okay. Now bring us to the discussion of anaphylaxis. Anaphylaxis could happen from food, like nuts, shellfish, medication, beta-lactam antibiotic, insect stings. And you have vasodilation, hypotension, tissue edema, tachycardia, upper airway edema, like you have stridor, hoarseness, wheezing, bronchospasm, like in this patient. This is pretty serious. Cutaneous, urticaria, rash, pruritus, flushing. GI, like nausea, vomiting, abdominal pain. And you have intramuscular epinephrine. You want to do airway management and volume resuscitation, give fluid, epinephrine, intubate if needed, antihistamine, steroid, adjunct therapy, okay. Alright, now we have another patient, let's say 71-year-old guy, came in with fever, night sweat, cough, yellow sputum, 4 weeks, okay? And then you do chest x-ray, right? You see cavitary lesion in the right lower lobe. Okay, and then they ask you, okay, what would you do for this patient? So right lower lobe cavitary lesion and 71-year-old. Then you give IV ampicillin, this possible anaerobic infection, anaerobic abscess. You give ampicillin, sulbactam, which is unison, because the bacteria that could cause Provotella, Streptococcus, Bacteroides, Pseudomonas nocardia, Aspergillus, Mycobacteria. Other reasons could be Aspergillus is common. You're gonna see that a lot. Malignancy, diabetic. Okay, another case that you would see. 55 came in because of respiratory distress. He had a blood loss, given transfusion. So now you know what I'm going with this. They give you X-ray. There's bilateral opacities, okay, and then they ask you about diagnosis. Diagnosis: this one, trolley transfusion. Associated acute lung injury. This is transfusion associated acute lung injury. And now this brings us to the discussion. What is that transfusion associated lung injury? Could be new acute lung injury, like acute onset hypoxemia, PaO2, FiO2 less than 300, or oxygen saturation less than 90% on room air. And you'll see bilateral infiltrate on the frontal chest X-ray without evidence of left atrial hypertension, no circulatory overload. No ALI immediately before transfusion, no acute lung insult, you know. The onset of acute that occurs during or within 6 hours after the end of transfusion, more than one plasma containing product. So usually it happens within 6 hours. That's when it's kind of you think that could be associated lung injury. Okay. So in a summary, whenever you see that, you know you want to do, this is acute lung transfusion. Could usually happen like hypoxemia, shortness of breath 6 hours after transfusion. You give them fluid support, vasopressors, stop transfusion, even tell the blood bank, so that to prevent future incident with this patient. Alright, so this is one thing. Now we have another case. Let's say, okay, 45 came in with shortness of breath for 2 days, okay? There's third heart sound, there's crackles, you know, there's chest X-ray, shows like cardiomegaly. Okay, so like so CHF picture, okay? And the question is asking, how does BiPAP help this patient? So they want to know the relationship between BiPAP and cardiology. So the way it helps, because the BiPAP is going to pull the air into the lung, is going to give you more oxygenation. So the more blood is going to stay in the lung. So more air, more blood. This, and the end, is going to decrease preload, which help heart failure symptoms, which help acute decompensated heart failure. Okay, and that brings us to the discussion. What other situation you do non-invasive positive pressure ventilation, which is the BiPAP. COPD, somebody who has severe exacerbation for COPD would be helpful. Cardiogenic pulmonary edema, such as in this case. Another thing, acute respiratory failure, like post-operative hypoxemic respiratory failure, immunosuppressed patients, and to facilitate early extubation was very helpful. These are the indications. What are the contraindications when you never want to do that? If there is cardiac or respiratory arrest, beating arrest, if there is severe acidosis, 7.1 is not good. Acute respiratory distress, non-respiratory organ failure, unstable cardiac arrhythmia, hemodynamic instability, encephalopathy, GI bleed. This patient you may need to intubate. If they're in medical instability, that's number one. Second thing, inability to protect airways, like agitated and cooperative, inability to clear secretions, high aspiration risk, then you do intubation. No, you don't do BiPAP. And if there is mechanical issue, like if there is recent esophageal anastomosis, facial or neurological injury, deformity, upper airway obstruction. In this case, you do BiPAP. You don't need to have all of these things, you know. You want to do BiPAP. Alright. Now another case is important. You see 58-year-old man, okay, came in with COPD, developed pneumonia, so needed to be intubated. Now, this patient has peak pressure 44 and plateau pressure is 24, and they ask you what's the best next step. What does that mean? So what we're having here, the plateau pressure is elevated, but the peak pressure is elevated, but the plateau pressure is fine. So the plateau pressure, there's a lung disease, that plateau pressure would be high. So this indicates there's no lung disease, there's upper airway obstruction. So what management is airway suction. And that brings us to the discussion, when do you have increased peak? Could be due to multiple reasons. If there's normal plateau pressure less than 30, this means it could be bronchospasm, mucus plug, or biting in the trachea tube. Then you just like fix the upper airway issue. But if there's an increased plateau pressure, this could be pneumothorax. Then you do need decompression, pulmonary edema, may need Lasix. There's pneumonia, you need to change antibiotics, atelectasis, spirometry. Right main stem bronchus intubation, you need to take the tube out. So this is what could be causing increased the plateau pressure. Is something important to keep in mind. Okay, so let's review. This is a high yield topic. We discussed about the plateau pressure. We discussed about BiPAP. When do you do that? Decrease preload in heart failure. That's helpful. Discussed on when do you see TRALI, transfusion-related lung injury, with 6 hours of transfusion. Ambulatory back time for anaerobic anaphylaxis. You give epinephrine. Assist control is helpful for somebody who is not ready for extubation. When do you extubate somebody? Enteral nutrition is helpful as well. Make sure you know that. Decreased respiratory rate is a pretty good idea to know. If somebody's respiratory rate is high. CTAPE, somebody when there's Wells criteria, we talked about that. Heart tachycardia, hypoxia. A chest tube whenever there's pH is less than 7.2. And that the first section of the pulmonary.